This presentation will discuss the case of a 55-year-old male who initially presented with atypical chest pain, eventually receiving a diagnosis of spontaneous esophageal rupture, which is colloquially referred to as Boerhaave syndrome. The patient sought medical attention approximately 24 hours following the abrupt onset of substernal and epigastric abdominal discomfort. While the patient underwent an appropriate evaluation in the emergency department, a key differential diagnosis had been overlooked. Although spontaneous esophageal perforation is a rare occurrence with an incidence of merely 3 in 1 million cases, it stands as the most lethal form of gastrointestinal tract perforation, boasting mortality rates of nearly 90% when Boerhaave syndrome goes undiagnosed. This syndrome should always be considered in patients presenting with chest pain and a recent history of vomiting. Mackler's triad, characterized by the sequential occurrence of vomiting followed by intense chest pain, typically experienced retrosternally, along with the identification of subcutaneous emphysema upon physical examination, provides a suggestive constellation of symptoms indicative of esophageal rupture. It's worth noting that these classic triad symptoms are often erroneously attributed to other conditions such as myocardial infarction, pulmonary embolism, aortic dissection, ruptured aortic aneurysm, perforated peptic ulcer, Mallory-Weiss syndrome, pancreatitis, pneumonia, and spontaneous pneumothorax. Our patient is a previously healthy 55-year-old male who presented to the emergency department after experiencing a sudden onset of mid-epigastric abdominal and substernal chest pain. He had began to feel nauseous the previous afternoon, followed by 3 episodes of non-bilious, non-bloody vomiting preceding the onset of pain. Describing the pain as a constant cramping sensation rated as 10 out of 10, the pain also radiated towards the flanks and back. He stated that he had never felt pain like this before. He denied any recent travel, alcohol consumption, drug usage, tobacco usage, exposure to sick individuals, fever, rash, recent illness, or trauma. The patient also noticed difficulty in breathing when leaning forward and mentioned an associated headache. Laboratory analysis were conducted encompassing CBC, CMP, CRP, lactic acid, troponin, and inflammatory markers. Among the notable findings were an elevated white blood cell count of 12.4, an elevated ESR of 35, and an elevated CRP of 3.3. All other parameters fell within normal ranges. During the physical examination, the patient exhibited a temperature of 100.9 degrees Fahrenheit. Remaining vital signs were within the normal range. Upon examination, the patient was in the fetal position and appeared toxic. Though the physical examination, limited by his positioning, yielded no remarkable findings, and the initial studies, which included chest X-ray, CTA, CT abdomen and pelvis, as well as EKG, were also interpreted as unremarkable, the patient was admitted for further evaluation. It was at this time that our surgical team was consulted to see the patient. Following an in-depth interview, it was revealed that the pain had originated subsequent to episodes of vomiting. This revelation prompted a more meticulous review of the CT scan by the surgical team, leading to the identification of an air collection adjacent to the esophagus. A subsequent gastrophin and swallow confirmed the diagnosis. As a result, the patient was transferred to another facility for the management of esophageal perforation. He received conservative treatment involving broad-spectrum antibiotics, which included vancomycin, meropenem, and fluconazole. He was NPO status for 72 hours, and a repeat swallow evaluation demonstrated sealing of the perforation. The patient was discharged in satisfactory health 2 weeks later. This case underscores the significance of conducting a comprehensive history and physical examination. By doing so, physicians are better equipped to navigate diagnostic challenges and arrive at more comprehensive and accurate diagnoses. As such, Boerhaave syndrome, due to its high association with morbidity and mortality, should be considered when evaluating a patient with atypical chest pain, especially when the history provided is consistent with this diagnosis.